Myeloproliferative neoplasms. So myeloproliferative neoplasms are a group of diseases where the bone marrow makes too many red blood cells, white blood cells, or platelets. First one we'll talk about is chronic myeloid leukemia. So chronic myeloid leukemia, or CML, is a myeloproliferative neoplasm that is characterized by uncontrolled proliferation of myeloid cells, particularly the granulocytic precursors. So the hallmark abnormality, you're going to want to remember this, is the presence of the Philadelphia chromosome, which is a translocation between chromosome 9 and 22. This translocation creates the BCR-ABL1 fusion gene, which encodes an abnormal tyrosine kinase protein, which causes uncontrolled cell growth. For clinical features, so common symptoms and signs include frequent infections, which are due to the impaired immune function despite elevated white cell counts, anemia, which results from the ineffective hematopoiesis. They also have bleeding tendencies due to thrombocytopenia or platelet dysfunction. They can also have splenomegaly, which is often massive due to the extramedullary hematopoiesis and sequestration of abnormal blood cells. The incidence of CML accounts for approximately 20% of all leukemia cases. It's most commonly going to affect men aged 46 to 53 years old, though it can occur at any age. The incidence usually peaks at about middle age. So back to that Philadelphia chromosome. The Philadelphia chromosome is considered diagnostic for chronic myelogenous leukemia. It results from a reciprocal translocation between the ABL gene on chromosome 9 and the BCR gene on chromosome 22. This fusion gene encodes a constitutively active tyrosine kinase, which drives leukemic cell proliferation. For molecular genetics, the BCR-ABL fusion protein continuously signals for cell division and actually inhibits DNA repair mechanisms, which leads to the clonal expansion of the leukemic cells. For molecular testing, or PCR, for the BCR-ABL transcripts is essential for diagnosis. We can monitor treatment response and detecting relapse. For laboratory features on the peripheral blood and bone marrow, we are going to find marked leukocytosis with a full spectrum of myeloid cells, which will include myelocytes, metamyelocytes, and neutrophils, and really any of their precursors. Neutrophilia is prominent, often with increased basophils and eosinophils. Thrombocytosis, where they have an elevated platelet count, is frequently observed as well. Bone marrow is usually hypercellular with granulocytic hyperplasia. The presence of basophilia and eosinophilia alongside neutrophilia is characteristic of chronic myelogenous leukemia. So really just kind of a brief summary. Chronic myelogenous leukemia is a myeloproliferative disorder driven by the Philadelphia chromosome translocation and the BCR-ABL fusion gene. Clinical features include the infection, anemia, bleeding, and splenomegaly. Laboratory features can show leukocytosis with neutrophilia, basophilia, eosinophilia, and thrombocytosis. And then diagnosis is generally going to be confirmed by cytogenetics or molecular detection of that Philadelphia chromosome gene. All right, so chronic myelogenous leukemia has a progression of the disease, and it typically follows a triphasic clinical course with distinct phases of the disease progression. The first phase is the chronic phase. The duration can last several years, often 3 to 5 years or more with treatment. Characteristics of this phase are most patients are going to be diagnosed in this phase. They will show marked leukocytosis with increased mature and immature myeloid cells. Patients often have mild or no symptoms during this phase, and the bone marrow shows hypercellularity with granulocytic hyperplasia. We also can see the Philadelphia chromosome and the BCR-ABL fusion gene during this phase as well. The next phase is the accelerated phase. It's the transition phase between chronic and blast crisis. Characteristics of this phase is that there's increasing numbers of immature myeloid cells or blasts in the blood or bone marrow. So it's about 10 to 19% blast now. Presence of additional cytogenetic abnormalities like clonal evolution. We can have progressive symptoms such as fatigue, weight loss, and splenomegaly. We can also have increased basophilia, and thrombocytopenia or thrombocytosis can occur during this phase. They can also have some resistance to treatment, can often develop, and that's usually during this phase as well. The disease usually starts to become more aggressive during this phase, and patients start to experience worsening blood counts and clinical symptoms, and they might start to require more intensive treatment. Then the last phase is the blast crisis, or the blast phase. This is terminal, and this is where the acute leukemia-like phase kind of is. So now the characteristics, we have blast cells. Now you're going to see greater than 20% in peripheral blood or bone marrow. It may resemble acute myeloid leukemia or acute lymphoblastic leukemia because of all those blasts that are being shown in the blood. Patients may have severe anemia, thrombocytopenia, and leukocytosis. They may have extramedullary blast infiltration. Generally, it's a poor prognosis, and it's going to resemble acute leukemia at this phase. So really, they're going to have marked clinical deterioration during this phase. Resistance to therapy is common, and generally there is a high mortality without aggressive treatment, such as like a stem cell transplant. For treatment of chronic myeloid leukemia, we have different options at least. The first one is an alkylating agent. An example of that would be busulfan. So the mechanism of this is it can cross-link of DNA, and that leads to cell death. It was historically used to control leukocytosis and some symptoms, but some limitations is it has toxic side effects, and it's less common now due to some newer therapies out there. The next one is hydroxyurea and 6-mercaptopurine. So bear with me here because I'm not a pharmacist. Hydroxyurea inhibits DNA synthesis by blocking ribonucleotide reductase, and that's used to rapidly reduce elevated white blood cell counts. It is well tolerated, and it is an oral administration. Next one is alpha interferon, and the mechanism, how it works is it modulates the immune response. It has anti-proliferative effects on leukemic cells. So before tyrosine kinase inhibitors, it was a major treatment. In fact, it can induce hematologic and cytogenetic remission. Some limitations though, the side effects include like flu-like symptoms, fatigue, depression, so it's not used as commonly now. Then we have cytarabine. The mechanism is it does a pyrimidine analog that inhibits DNA synthesis. It was used in blast crisis or accelerated phase as part of combination chemotherapy. Some limitations, primarily a chemotherapy agent. It was used when more aggressive treatment is needed. Patients can also have a bone marrow and stem cell transplant. It's a potentially curative treatment. When we use it, it's usually considered for younger patients, those that are in accelerated or blast phase or resistant to other treatments. Some risks that come with this is we can have transplant-related mortality. We can also have graft versus host disease come from this as well. The outcome, though, is it offers long-term remission or cure, actually, in some cases. The next one is modern therapy. So as mentioned earlier, that tyrosine kinase inhibitor, it works by specifically inhibiting the BCR-ABL tyrosine kinase, so the fusion protein that was responsible for the chronic myelogenous leukemia pathogenesis. Advantages, it is a targeted therapy, so it has fewer side effects. It can transform chronic myelogenous leukemia into a manageable chronic condition. There are high rates of hematologic, cytogenetic, and molecular remission with this as well. Downside is there is some resistance. So some patients develop resistance or intolerance that requires second or third generation tyrosine kinase inhibitors. We also need to do monitoring, so regular molecular monitoring of the BCR-ABL transcript levels is essential to make sure the response is appropriate. This is a picture of what chronic myelogenous leukemia looks like. We'll move on to polycythemia vera. This is a rare disorder. It's classified as a myeloproliferative neoplasm. It will typically affect middle-aged adults, usually between 40 to 60 years old, and it is more common in men than in women. There's also a higher prevalence reported in the white populations. For diagnosis, polycythemia vera involves a combination of clinical, laboratory, and molecular criteria, and that's typically based on guidelines from the WHO. So for clinical features, Symptoms are going to be related really to an increased red blood cell mass and blood viscosity. So patients can have a headache, dizziness, visual disturbances. They can have fatigue. They can have splenomegaly. They can have thrombosis and bleeding as well. As far as the laboratory findings go, they're going to have an elevated hemoglobin or hematocrit above the normal reference range. They're going to have increased red blood cell mass. They're going to have leukocytosis and thrombocytosis, possibly. It could be normal as well. That one kind of goes back and forth. They could have low serum erythropoietin level, and that's due to the feedback suppression. As far as the bone marrow examination goes, you'll typically see a hypercellular marrow with increased erythroid, granulocytic, and megakaryocytic proliferation. Presence of megakaryocyte hyperplasia with pleomorphic mature forms may be present as well. For the molecular testing, you'll have the JAK2 V617F mutation will be present in greater than 95% of the cases. So rarely mutations in the exon 12 of JAK2 may be found. Detection of JAK2 mutation confirms and supports diagnosis of polycythemia vera. For diagnostic criteria for who, they would have to have elevated hemoglobin or hematocrit or an increased red cell mass. The bone marrow biopsy would show hypercellularity with trilineage growth. They would also have to have a presence of the JAK2 V617F or JAK2 exon 12 mutation present. For the minor criterion, you'd have subnormal serum erythropoietin levels. The diagnosis for that will require all three major criteria or the first two major criteria and one minor criteria. And that is listed there on your slide as well. This is just laboratory features for polycythemia vera. It'll tell you what should be increased or decreased. It's really just an overview of what we just talked about. And that is what a slide would look like as well. As you can see, it's very condensed and packed with those red blood cells. It normally does not look like that. So polycythemia vera clinical presentations, they will lots of times present with hypertension, and that's often due to the increased blood viscosity from elevated hematocrit. They can come with a headache, weakness, fatigue, and weight loss, and these are common nonspecific symptoms to polycythemia vera. They can have itching, especially after a warm bath or shower. Other symptoms may include dizziness, visual disturbances, splenomegaly, and thrombotic events due to the hyperviscosity and increased platelet count. For treatment, you can do therapeutic phlebotomy. That is a treatment to reduce hematocrit and decrease the blood viscosity. They can also do myelosuppressive therapy, which is used in high-risk patients or those with thrombosis. Examples include hydroxyurea or interferon alpha. Targeted molecular therapy is that tyrosine kinase inhibitor, which can target JAK2 mutation in resistance or if they have a more advanced case. You can also do supportive treatment to help manage the symptoms and prevent any further complications for the patients. An example of that would be like a low-dose aspirin to reduce the thrombotic risk. For prognosis, we have a median survival range from 10 to 20 years with proper management. Approximately 15% of patients may progress to acute leukemia or myelofibrosis. So there's a risk of thrombotic complications, remains a major cause of morbidity and mortality. So early diagnosis and treatment will significantly improve quality of life and outcomes for these patients. Essential thrombocythemia. So this is a myeloproliferative neoplasm that is characterized by the overproduction of platelets due to clonal proliferation of megakaryocytes in the bone marrow. The excessive platelet production can lead to thrombosis or hemorrhage due to dysfunctional platelets. Luckily, it is a rare disorder, but it does most commonly affect women aged 50 to 60 years old. And as mentioned earlier, there is a slight female predominance. For clinical presentation, many patients are actually asymptomatic and discovered accidentally by a routine blood test. Symptoms, if they are present, are related to vascular complications. So we could have vascular occlusion, which could lead to a transient ischemic attack, a stroke, a myocardial infarction, or deep vein thrombosis. You can also have hemorrhagic events due to platelet dysfunction despite a high platelet count. Some other symptoms, you'll hear these all the time: headache, dizziness, maybe some visual disturbances, maybe a burning pain in your extremities, and splenomegaly in some cases as well. As far as diagnosis goes, it requires fulfillment of either all 4 major criteria or 3 major criteria plus 1 minor criteria. These are listed on the slide below, so I'll let you go ahead and read those. As far as laboratory features, so peripheral blood, you have marked thrombocytosis, so platelet counts are often greater than 450 and sometimes greater than 1,000. Platelets may appear large and abnormally shaped. You may have mild leukocytosis, and sometimes mild anemia may be present as well. For the peripheral smear, it's going to show large platelets. Sometimes you'll see platelet clumping too, and really there's no significant abnormalities with red cells or white cells. For the bone marrow, you're going to see hypercellular marrow with predominant megakaryocytic proliferation. Megakaryocytes are large, mature, with hyperlobulated nucleoli. There'll be little to no increase in the granulocytic or erythroid lineages. Mild increase in reticulin fibers may be observed, and no fibrosis typical of primary myelofibrosis. For treatment of low-risk patients, if they're less than 60 years old and have no history of thrombosis, this is often going to be managed conservatively with just some low-dose aspirin to reduce that thrombotic risk. If they're high-risk patients, so over 60 years old, they have a history of thrombosis, or they have very high platelet counts, we can do cytoreductive therapy with hydroxyurea. Some alternatives include anagrelide or interferon alpha, especially in younger patients or during pregnancy. We want to control the cardiovascular risk factors like hypertension and smoking. Platelet pheresis may be used in emergency situations with extreme high platelet counts and active thrombosis or bleeding. As far as prognosis goes, this is generally favorable with proper management. So the median survival can be or exceed 10 to 15 years. The main risks for this are really going to be your thrombosis and hemorrhage, which can lead to morbidity and mortality. So around 10 to 20% of these patients may progress to myelofibrosis or acute leukemia. So regular monitoring is necessary to manage complications and adjust treatment if needed. For primary myelofibrosis, there are a couple alternative names. So it could be called chronic idiopathic myelofibrosis, egnogenic myelofibrosis, or myelofibrosis with myeloid metaplasia. So features of myelofibrosis is characterized by overproduction of collagen fibers in the bone marrow. This fibrosis disrupts the normal bone marrow architecture. Hematopoietic tissue is progressively replaced by the fibrous tissue, which leads to pancytopenia, which is the deficiency of all blood cell types, red blood cells, white blood cells, and platelets. It results in extramedullary hematopoiesis, so blood cell production outside the bone marrow, which is going to be commonly in the spleen or liver. This will mostly affect individuals over 60 years old, and this is often a slow and chronic disease with an insidious onset. Many patients are asymptomatic initially, and when symptoms do start to occur, they are usually related to anemia, so fatigue, weakness, and some heart palpitations. Other symptoms may include splenomegaly and some bone pain. For laboratory features for myelofibrosis, on the peripheral blood smear, we will see presence of immature granulocytes, so we'll see myelocytes and metamyelocytes. We'll also see the presence of nucleated red blood cells. We'll also see our red cells being normocytic and normochromic. We'll have variable white blood cell counts, so they could have like leukocytosis or leukopenia. They could also have thrombocytosis or thrombocytopenia, and it really is going to depend on the disease stage. For red blood cells, we may see teardrop or dacrocyte-shaped red blood cells. This is a characteristic finding due to the marrow fibrosis and mechanical distortion. We're going to see polychromasia and anisopoikilocytosis, which is a variation in red blood cell size and shape. For bone marrow findings, we're going to see hypercellular marrow initially, but with the progressive fibrosis, it will start to deteriorate. We're going to see marked reticulin and collagen fibrosis, leading to replacement of normal hematopoietic tissue. Megakaryocyte proliferation with atypical clustered and dysplastic forms. Decreased erythroid and myeloid precursors as fibrosis progresses. And the bone marrow aspiration is going to oftentimes be referred to as a dry tap, and that is due to extensive fibrosis, which makes the biopsy necessary for diagnosis because they're not able to pull any fluid out of the bone marrow. For the immune response, so we have humoral immune response. It's altered in approximately 50% of patients. They will have the presence of autoantibodies, which will target their red blood cell antigens, nuclear proteins, gamma globulins, phospholipids, and organ-specific antigens. These autoantibodies may contribute to clinical complications and immune dysregulation. For treatment, it's primarily going to be palliative, focusing on the symptom relief and supportive care. Management of the complications, such as anemia, so you may require transfusion or erythropoiesis stimulating agents. Hepatosplenomegaly may cause discomfort or abdominal fullness. Treatment may be supportive or involve splenectomy in severe cases. There is no definitive cure except allogenic stem cell transplantation, which is really just limited to select patients due to age and comorbidities. For prognosis, the median survival is about 5 years, but this can vary widely depending on patient and disease progression. Disease progression typically leads to bone marrow failure, and common causes of morbidity and mortality include infections due to immunosuppression, hemorrhage from thrombocytopenia and marrow dysfunction, cardiac failure due to anemia and organ stress, or transformation to acute leukemia that went on to the blast phase. Some other myeloproliferative neoplasms, we have chronic neutrophilic leukemia. Its incidence is it's a rare myeloproliferative disorder, and it will typically affect individuals around 67 years old. It occurs in both men and women. For presentation, they will usually present as asymptomatic initially, and when the symptoms do start, they will usually have that fatigue, weight loss. They'll have some easy bruising. They may have an enlarged liver and spleen, and they may have some bleeding from their mucosal sites like their gums or their nose. For laboratory diagnosis, they'll have a white blood cell count greater than 25. Neutrophils will make up greater than 80% of that white cell count. They will also have a presence of toxic granulation in the neutrophil, which indicates an activation or inflammation. Peripheral blood smear and bone marrow examination to confirm diagnosis and exclude any other cause will be needed for diagnosis. For the prognosis, it's variable, just kind of depends on the patient. Can be anywhere from 6 months to over 20 years, but the median survival is about 2 years. Another myeloproliferative neoplasm we're going to talk about is chronic eosinophilic leukemia. Patients who have this will present with symptoms like a fever, fatigue, muscle pain, and itching. Can lead to complications such as endomyocardial fibrosis, which is fibrosis of the heart lining, which can cause cardiac dysfunction. Can also have central nervous system dysfunction as well. As far as laboratory diagnosis on our side, we're going to see eosinophilia, we're going to see neutrophilia, we're going to see a presence of some blasts in the peripheral blood and bone marrow. For the bone marrow biopsy and molecular studies, they're going to be needed to differentiate from other eosinophilic disorders. There is no definitive cure. And for treatment, it's really just symptomatic treatment with hydroxyurea, and that will help to control leukocytosis and eosinophilia. Prognosis is generally poor. The survival, median survival rate is about 22 months. And approximately 50% of these cases will progress to acute myeloid leukemia.